We're going to get started. We're very lucky to have Stephanie Brennan with us to begin today's talk. She's a pharmacist based at St. Vincent's, Birmingham. She's going to give the first half, and then she'll transition to me, and we look forward to hearing what she has to say. Thank you for being here.
Thank you, Dr. Middlebrooks. Hi there. I'm Stephanie Brennan. I'm currently a PGY1 pharmacy resident at St. Vincent's, Birmingham. So for the first part of our noon conference today, I'm going to talk to you broadly about antimicrobial stewardship. What do we mean when we say that? What exactly is an AMS program? And then in the second half of our talk, Dr. Middlebrooks will take over and discuss more specific ways that our health system is implementing successful stewardship strategies. So by the end of our talk, you should be able to describe the importance of AMS in the acute care setting, evaluate the principles and objectives of AMS programs, and identify methods for implementation of a successful program in a community health system. So first, what is antimicrobial stewardship? We use antibiotics all the time, but what do we mean by stewardship? So according to the Infectious Diseases Society of America, antimicrobial stewardship refers to the coordinated interventions that are designed to improve and measure the appropriate use of antibiotics by promoting the selection of the optimal drug regimen, the optimal dose, the duration of therapy, and route of administration. So now we know what it is. Why does it matter? So in 2019, the Centers for Disease Control and Prevention estimated that more than 2.8 million antibiotic-resistant infections occur in the U.S. each year. They also estimate that more than 35,000 deaths occur as a result of these resistant infections. Now we know that prompt initiation of antibiotics, like in the case of sepsis, is life-saving. It has reduced mortality. However, 30% of the antibiotics that are prescribed in our acute care facilities are either unnecessary or considered suboptimal. So this can risk directly harming our patients in the form of adverse drug events and indirectly causing harm through the spread of antibiotic-resistant organisms. So what stewardship programs aim to do is work to optimize antibiotic use to protect our patients from harm and to combat this resistance. They've been shown to increase infection cure rates while also reducing treatment failure, hospital costs, and length of stay. All right, so we've established what it is, why it's important. So what do we do with that information? How do we roll out these programs that they're talking about? And what do our programs look like here? So to assist hospitals in effectively implementing stewardship programs, the CDC released a document detailing 7 core elements of hospital antibiotic stewardship programs. Since its publication in 2014, these core elements have served as the foundation for antibiotic stewardship accreditation standards from the Joint Commission and as a reference for recent 2019 CMS guidelines for antimicrobial stewardship programs in hospitals. So in the following slides, we'll cover the 7 core elements and their role in creating a successful stewardship program. Our first core element, start top down, is hospital leadership commitment. For a stewardship program to truly be successful, and this won't surprise anyone, we have to have support from our leadership. So what does that look like? According to the CDC, it's providing dedicated time and resources to our leaders of our antibiotic stewardship programs to operate the program successfully, provide daily interventions, and also ensure that we're having regularly scheduled opportunities to report this not only to our hospital leadership, but also to all of our associates. Our next element is accountability. Here, accountability means having a designated leader or co-leaders who are responsible for program management and outcomes. According to a 2019 National Healthcare Safety Network hospital survey, 59% of hospitals in the U.S. Have stewardship programs that are co-led by a physician and a pharmacist. And of course, it's important in these programs that we have delineated roles and responsibilities And that we also recognize when our physician leaders may have obligations at other facilities, that we have something in place to support our co-leaders. So since prescribing falls under the direction of the medical staff, it's important if we have a non-physician leader, like a pharmacist, that we designate a physician point contact so that they have support and can ensure that our patients don't have delays in care, et cetera. So regular stewardship rounding for the co-leaders has been found to strengthen program leadership, of course, but also strengthen prescribing practices within the facility. And you'll hear me say this again and again, but doing that in person has actually been shown to be even more effective. Our third element is pharmacy expertise. So in the 2014 guidelines, this was called drug expertise, but they've just updated it in 2019, and now we're calling it pharmacy expertise. So the highly effective stewardship programs have strong pharmacist engagement, usually either as the leader or the co-leader of the program. Pharmacists play a vital role in our day-to-day evaluation of our antibiotic stewardship interventions. This role works best, of course, when communication is open and encouraged from leadership. And I'm going to say it again, when we do it face-to-face. Action is our fourth core element. Performing an initial assessment of antibiotic prescribing habits within a facility can help identify our opportunities for where we can get better. Two of the most effective and foundational interventions for hospital stewardship are prospective audit and feedback and pre-authorization, which I feel like these are two big words for things we're already familiar with. Prospective audit and feedback, also called post-prescription review, is an external review of our antibiotic therapy that's conducted by the stewardship program, and then can offer suggestions to our prescribers about our duration, our optimal use, et cetera. So this can be helpful or implemented in different ways. So if we have a smaller hospital, for instance, which we know we do in our health system, or if we have newly implemented programs, you might start out not by having a complex therapy review, but just identifying common conditions. So community-acquired pneumonia, skin and soft tissue infections, and then comparing what the hospital's current prescribing practices are to what current guidelines suggest. The second foundational intervention that I mentioned is pre-authorization. So pre-authorization is when you want an antibiotic, but you got to have somebody to approve it. So it requires our prescribers to gain approval before we initiate that order. Decisions on which antibiotics should be included in this should be facility-specific or system-specific. And that should happen as a conversation between our prescribers, our providers, and our ID expertise. So tracking helps us keep track of how successful we are with our interventions. It measures the success of our program and provides regular evaluation of both our processes and our outcomes to ensure that we're having great success. Antibiotic use can be recorded using a lot of different tools. I think we all use different ones. One that pharmacy uses is Century 7. But also more broadly, the hospital itself can use the National Healthcare Safety Network's antimicrobial use option, or even use pharmacy record systems to review antibiotic use. So often in the case like of C. diff reporting, we're already measuring these outcomes. We're already reporting on them for CMS requirements. So that's fantastic. But another outcome that a program should be assessing is antibiotic resistance, which is sort of a nebulous thing. Like how do we go about doing that? So to assess resistance, it's important that we analyze and focus on the pathogens that we obtain, so our culture data, from our patients who have been admitted and have then been under the influence, if you will, of our antimicrobial stewardship team. And though cost savings is not our primary goal, it's something I think we all love and know is very effective. Cost savings, particularly through drug cost savings, can often be helpful in securing more resources for our antimicrobial stewardship programs. Reporting is our sixth core element. So I've said this again and again, but programs should provide regular reports of updates to their prescribers, to their leadership, to their hospital board, and look at outcome measures and processes at both a national and a local level. And that includes, of course, antibiotic resistance. So I bring up resistance again because that's something we can collaborate with our microbiology lab, with our Department of Health, and we do that annually actually when we create our antibiograms. And then we then should be sending this data out to our associates, to our pharmacists, our physicians, our nurses, et cetera. So sharing that facility-specific information on antibiotic use with our providers, whether it's through medication use evaluations, through our AMS meetings, it can be an excellent tool to help motivate people to change prescribing habits. And I'll say it again, it's always best in person. So our last core element is education. Education is a key component to any successful antimicrobial stewardship program. So, but it can't function alone. It has to be paired with our interventions and our measurements to really have an impact. So case-based education can often be the most productive tool to use to show this to our providers. Again, feedback in person is the best way to do this and has been shown to be the most effective means of really changing our habits. So how are we implementing that here? What is this, maybe some of you wonder, do we even have an antimicrobial stewardship program? I hope that's not true, but here we have a system-wide approach. I think that's important, it's a little unique, and I think it gives us a lot of opportunities. So we know that our system includes Birmingham, East, and then our regional facilities at Blount, St. Clair, and Chilton. I'm only going to touch on this briefly so I don't steal the show from Dr. Middlebrooks, but our AMS practices here include regular review of our antibiotic use. And I know in pharmacy we are constantly performing medication use evaluations and looking at what our prescribing habits are, how do we land in comparison to Ascension national benchmarks. And we have monthly AMS meetings that are on the third Wednesday of every month. So here's some resources, more information if you are interested. And then I will turn it over to Dr. Middlebrooks. Thank you.
Thank you very much. Can everyone hear me without any difficulty? Stephanie, thank you so much for that. I really appreciate it. I look forward to continuing to work with you on antimicrobial stewardship, and I value you very much as a resource, and thank you again for coming. Lisa, do I hit the up arrow or the right arrow? That wasn't it. Let's try this. I'm stuck. There you go. What do I do to go forward? That one? Gotcha. All right, when Lisa asked for an infectious diseases update sometime calendar year 2000, I started looking at potential topics. C. diff is always a good topic, and there's always something new about C. diff. I found an article on the newly arrived Asian long-horned tick and thought that at some point it might be fun to discuss a new potential vector. I found a recent article about chronic pulmonary aspergillosis and optimal antifungal therapy that I thought was interesting. Maybe we can discuss that sometime. There's also new information about that's supposed to be STRs for PEP, single tablet regimens for HIV post-exposure prophylaxis. And as you just heard, antimicrobial stewardship is a high priority, and Stephanie just gave pretty much the definitive, current, up-to-date discussion of antimicrobial stewardship. I was going to talk about how we're implementing that at St. Vincent's East. However, due to the ongoing Sars-CoV virus, coronavirus 2 outbreak, other topics have been preempted for a discussion of coronaviruses, and we're going to talk about coronaviruses for the rest of the time. Coronaviruses were first described in 1965. They were named because of the crown-like appearance, the corona, of the surface projections that are seen on electron microscopy. They're single-stranded RNA viruses. They have an envelope with the glycoprotein surface projections that we've already made reference to. They're primarily respiratory pathogens in humans. Interestingly, they're also a cause of viral diarrhea as well. Lisa, I know I did not give you these slides with these typos in here. Coronaviruses cause a wide variety of diseases in animals: respiratory, enteric, hepatic, and neurologic. Unfortunately, they mutate frequently and they readily infect new species, which has led us to the current situation we're in. We know that with coronaviruses and with many other viral infections that respiratory disease in humans occurs more often in the winter and spring. I tried to find some recent data about something more scientific than just my theory that people are jammed up closer together when the weather's bad. It's kind of difficult unless you're looking for advanced papers on epidemiologic theory about why these infectious diseases tend to be seasonal. Some of the obvious things you're going to run across if you look this up will be malaria outbreaks after a rainy season has begun. Beyond those obvious things, viral diseases have been more prevalent in the wintertime long before we had school years that started in August or September and ended in April or May. So there's something else going on. We're just not quite sure what. Interestingly, coronaviruses cause about 15% of common colds, and we'll talk about some of those coronaviruses in a minute. Unfortunately, reinfection with coronaviruses, specifically the non-SARS, non-MERS coronaviruses, is common. There's been demonstrated to be a rapid diminution of antibody levels after infection. And I don't know that anybody can say what this means for vaccine development for the current COVID-19, I won't say pandemic yet, but outbreak. Time will tell on that. The original SARS outbreak, I've seen it referred to as just SARS coronavirus. I saw one article yesterday that called it Sars Coronavirus 1. SARS stands for Severe Acute Respiratory Syndrome. This began in China in November 2002. The case fatality rate was 7 to 17%. The number I've seen quoted more often is 10%. Up to 50% of those chronically ill or greater than the age of 65 expired from this illness. The World Health Organization's control program consisted of the following, a lot like we've done currently in the current outbreak: isolation of cases, infection control precautions, specifically contact, droplet, and airborne, quarantine, and travel advisories, and we're right in the middle of all that now. Encouragingly, global transmission ceased by July of 2003. So they went from November to July, and then it was done. And since so much of what's going on now is similar to what went on then, I'm hoping that we'll see this as well. We know that the original Sars coronavirus originated in horseshoe bats in China. And scientists have also demonstrated that the intermediate hosts were these small mammals that are just not familiar to me, but they're called the palm civet and the raccoon dog, and they're kept in cages and slaughtered in the markets. And they've also shown that the people at the markets that were carriers of the SARS coronavirus 1 were actually the stall handlers, the people who brought these mammals to the market. The unfortunate thing that happened after development of the infection in the intermediate host and then spread to people was person-to-person spread. We think that droplet transmission and direct contact are probably the most important. There are a lot of people that are really hoping that the CDC is going to come out and say that droplet transmission is the main method, and that way we can stop worrying about the N95 respirator masks and just concentrate on droplet precautions. And I'm going to end the talk actually with a discussion of precautions. Back then, in the 2002-2003 original SARS coronavirus outbreak, most individuals transmitted to very few others, an estimate of 3 people. If you read about that outbreak, you're going to read about super spreading events. And super spreading is something I've heard again with this ongoing outbreak. It's been somewhat difficult to define, but there are epidemiologic implications that one or perhaps more than one unusual outside the bell curve individual for whatever reason is spreading lots of virus with droplet nuclei that travel far and circulate for a longer time, and they've just been calling that super spreading events. But again, if you try to find really hard documentation about it, you're going to see more speculation than anything. Unfortunately, in the original outbreak, spread in hospitals was described as efficient. Luckily, when the hospitals implemented droplet and contact precautions, they were effective in suppressing transmission within the hospitals. You really can't do a talk like this without at least mentioning the MERS coronavirus. I'm not going to say anything else about it other than it was short-lived. The overall global impact was less, even though the mortality was higher. The mortality for this particular illness was about 30%. Let's talk about what's going on currently. SARS Coronavirus 2, which causes COVID-19. How many name changes have there been since this started? I'm not really sure. And if you want to talk about how scientists name things, I've got some, I think, entertaining anecdotes about names that were suggested for Clostridium difficile before it became Clostridioides difficile. So name changing is not just something that's gone on with this. We know that clusters of patients with pneumonia of unknown cause were epidemiologically linked to a wholesale market in Wuhan, China in December of 2019. As of the 24th of February, there were 75,000 cases with a 2.7% mortality. And as of this morning on the World Health Organization website, there were 88,948 confirmed cases globally, 3,043 deaths, and that's 3.4% mortality. Keeping up with this has been challenging. It's been fascinating, and it's getting a little bit more concerning. That increase in mortality, I think, has gotten everyone's attention. The illness was first called novel coronavirus infected pneumonia. It's now called COVID-19, caused by Sars Coronavirus 2. The other coronaviruses that infect people are just given alphanumeric designations. They're just not important enough to really get fancy names. 229E, OC43, just for example, OC I think stands for organ culture, or just something that mundane. NL63 and HKU is Hong Kong something 1. These 4 viruses typically cause common cold symptoms in immunocompetent people. The original case definition of the pneumonia of unknown etiology is as follows. Obviously, no pathogen is identified in a patient with fever, with chest x-ray evidence of pneumonia, with a white blood cell count that's normal or low, with a lymphocyte count that's low, with no improvement after 3 to 5 days of standard treatment. As the number of cases grew, travel history was added to the case definition, and we'll be checking the CDC website frequently to see how they update and adjust the case definition. That's going to be important for testing implications. There was an article in the New England Journal at the end of January discussing early transmission dynamics in China. They looked at 425 patients that had COVID-19. The median age was 59. 56% of them were male. The mean incubation was 5.2. As you read about this every day, as you hear about it on the news, on the TV, on the radio going home, there's a lot of different talk about people being let out of isolation too soon, which I think is very concerning, about asymptomatic transmission, which is also concerning. But at least based on these data, we're going to stick to the fact that mean incubation is probably about 5 days or so. Also, when these patients were examined, every case spread infection to approximately 2.2 other people. This is the basic reproductive number based on the epidemiologic analysis in that group of 425 patients. Again, spread seems to occur mostly by large droplets and by contact. Again, super spreading events have been implicated but are not really well documented. It'll be interesting to see if we can actually document the frequency of super spreading and exactly what leads to it. If you're in the middle of something like this and you're trying to read the literature and keep up on a day-to-day basis of what's going on, you're going to run into a lot of interesting things, and this was just something I thought that we needed to review as we're in the middle of this. The impact of an epidemic depends on the following things. One is the number of people with infection, and that number of people, or estimated number of people with COVID-19, is growing as more asymptomatic patients are discovered. The transmissibility of infection is also important. We think this is probably a much more transmissible infection than was initially realized. And the spectrum of clinical severity, which is obviously ranging from asymptomatic to death. How transmissible is it? In this New England Journal article, they looked at 14 patients that had been to Wuhan, and they cohorted them based on symptoms and fever. Fever was the main thing. So the one person of this group of 14 that had no symptoms did have fever, which is why he was included in this bunch. Everybody else had some sort of cough, sore throat, sniffles, something. The interesting thing was that when they did a viral load analysis on all these people, symptomatic and the one asymptomatic included, everyone had a similar viral load. And so from this, we're wondering, is this asymptomatic person just as infectious as the symptomatic patients? They noted that there were higher viral loads detected in the nose rather than the throat, which seems to have some sort of implication regarding droplet transmission and ease of transmissibility by way of droplets. And they also drew the conclusion that the elevated viral load in the asymptomatic patient suggests that disease transmission may occur early in the course of infection, which is also concerning. Enough time has not really gone by yet to correlate viral loads with how much virus can be cultured. They are culturing virus now, but there just hasn't been enough time to collect all that data. So really we're left with the fact that prevention is key. We're going to talk about treatment in a minute, but we're going to talk about prevention first. There's no vaccine yet. Estimates have varied from a year to a year and a half as far as when a vaccine may be ready. Non-SARS, non-MERS coronaviruses don't necessarily elicit lifelong immunity. I'm not sure why this should. I hope it will. As far as prevention and treatment, according to the CDC, the best way to prevent infection is to avoid being exposed to the virus. The CDC also recommends wash your hands often with soap and water. Avoid touching your eyes, nose, and mouth with unwashed hands. Stay away from people who are sick. Stay home when you're sick. Clean and disinfect frequently touched objects and surfaces. I went ahead and put this slide in here, well, this next few, when there was the report that they might bring cruise ship refugees to Alabama. That created a fair amount of local interest. In Anniston, there is a Center for Domestic Preparedness at the former site of Fort McClellan. It opened in 1998. It's currently managed by Federal Emergency Management Agency. This center trains first responders in disaster preparedness and response. On the 22nd of February, on a Saturday, FEMA announced a plan to transport patients from the Diamond Princess cruise ship to Anniston to this facility. This was not news that was well received. By the next day, by Sunday the 23rd, Governor Ivey, along with other politicians, announced that the plan to transport these evacuees to Alabama had been scuttled. They cited in particular the fact that the Center for Domestic Preparedness is a training facility and not a quarantine site. Just interestingly, since then, today's news says that there are a couple of patients in Florida that have been identified and a couple in Georgia. So in spite of the fact that we didn't bring cruise ship evacuees to Anniston, I think we're going to see this sooner rather than later. Other Alabama connections: Dr. Whitley, a virologist at UAB who was also my mentor when I was a fellow, has a grant from the NIH to develop antiviral agents. He's done this for years. It's very important work. It's very interesting work. And he simply has a knack, I think, for being in the right place at the right time. Because one of the promising agents that's under investigation is called remdesivir. It's an adenosine nucleotide analog. It's a prodrug, and it has broad spectrum activity against several RNA viruses. The active metabolite interferes with viral RNA polymerase. And that's the mechanism of action. It was actually studied against Sars Coronavirus 1 and MERS coronavirus. And based on promising results from those trials, a controlled double-blind trial has been designed to evaluate the efficacy and the safety of remdesivir in patients in China who are hospitalized with severe Sars Coronavirus 2 respiratory disease. So the trial is going to hopefully enroll 452 people. The start date of enrollment, 6th of February. The estimated study completion date is the 1st of May of this year. So I hope there's information before too much longer. I asked Dr. Whitley about this recently, and he promised to keep me posted on results as they come in. It's going to be really interesting to see how the trial progresses. In the trial, they're looking at remdesivir 200 milligram IV loading dose on day 1, followed by 100 milligrams IV daily for 9 days versus the placebo at the same dose. The trial outcome measures are as follows: death, ICU hospitalization requiring ECMO or invasive mechanical ventilation, intensive care hospitalization requiring non-invasive ventilation or high-flow oxygen, hospitalization not necessarily in the intensive care unit requiring supplemental oxygen, or not requiring supplemental oxygen. I'm not sure why they would be in the hospital, but that's one of the measures that's listed. Plus, obviously, they'll be looking at time to hospital discharge. The trial is to include patients who are 18 years and older. They have to have PCR-confirmed infection with Sars Coronavirus 2. They have to have an abnormal chest X-ray. They have to be hospitalized and be hypoxic, and they have to have been sick for 12 days or fewer. There are also, of course, exclusion criteria. The physician has the decision-making capability to say that participation in the trial is not in the patient's best interest. If the patient has severe liver disease, they're not going to qualify. If they're pregnant or breastfeeding, they're not going to qualify. Patients with severe renal impairment or dialysis patients are not going to qualify. They also specified that if a patient is anticipating transfer to a non-study site hospital within 72 hours, they will not be enrolled in this study. And I think the final exclusion criterion was receipt of any experimental treatment for Sars Coronavirus 2 within 30 days of enrollment. Let's remind ourselves about precautions, and then we'll have some time left over for questions. Precautions. Everybody's on standard universal precautions. Some people need airborne, some need droplets, some need contact, some need combinations. Standard precautions. Eye, mouth, and nose protection when you're engaged in a patient activity that's likely to generate a splash, a spray, or an aerosol. Gowns are required for activity likely to generate a splash or spray. Gloves for contact with any body fluid, mucous membrane, or non-intact skin. And, of course, hand hygiene before and after patient contact. Contact precautions. Single patient room. Do we even have rooms now that are not single patient? I don't think we do. I think this specification still exists. The door can stay open. Patient care equipment either needs to be disposable or dedicated to a single patient. Gowns on entering the room and gloves on entering the room. Droplet precautions, again, a single patient room, the door can stay open. Surgical mask upon entering, and a surgical mask on the patient for leaving the room to go to x-ray or whatever. And then airborne precautions mandate a negative pressure room, which is going to be a single patient room with air exhausted to the outside or through HEPA filters, and the door remains closed. For the healthcare workers, the N95 or portable respirator for entering the room, and again, the surgical mask on the patient for transport. We've got a few minutes for questions. Who would like to ask or comment or say anything? Yes?
What about alcohol-based hand rods everybody's buying? Is that effective against the virus?
I don't use it. I like soap and water. It's better than nothing. That's not a ringing endorsement. I think that alcohol-based products lead to dry skin. Dry skin is notorious for harboring pathogens just because of the physical properties, the cracks, the flakes, etc. I'm not a fan of alcohol-based products.
Can you repeat the questions when they have?
Yes.
I've had a lot of questions here about which unit this is going to be on, and what's our plan for isolation if we receive a patient.
Chase has asked what our plan is here for isolation. My understanding is that we expect somebody to come through the emergency department and not be admitted from an office, and so that's probably our primary focus. I know that the questions for determining whether somebody meets the case criteria for a patient under investigation have been put in place because we've sort of had a dry run with one patient early on, and I think everything went well. They went to 5 West in the negative pressure room, and as soon as it became clear that that individual did not really meet criteria to require testing, then they didn't meet criteria for isolation, and so we stopped the isolation. So at least through the ER, the pathway is tried, and I was satisfied with it, and yeah, I think we're ready. You know, we did this with Ebola a few years ago, and I think we've brushed up on our skills pretty quickly.
Thank you.
Yes?
Do we have the testing kits here on site, or is it something that we're still having to rely on the CDC?
BJ asked if we have the testing kits here on site, and somebody else called me earlier today to ask about testing. Testing is not available on a widespread basis yet. I expect it will be soon. Right now, we still have to go through the state health department, make sure a patient meets the criteria. We'll send specimens to the health department downtown. They'll send it to Montgomery, and Montgomery will send it to the CDC. That's kind of slow. I've tried to find out when tests will be commercially available. I'm not sure, but as soon as they are, I'm sure there'll be a run on them.
In the meantime, these individuals will be quarantined, right?
In the meantime, when these patients come in, for example, the patient we saw in February was admitted, placed on 5 West on airborne precautions, found to not meet criteria, taken off isolation. If a patient comes in and does meet criteria to be a patient under investigation, then we'll call the health department, we'll collect the specimens, and we'll send them off. I don't know what the turnaround time is. We're close enough to Atlanta. I would think maybe it's 48 hours. It may be less, it may be longer for PCR. I'm not sure about serum. But that's what we would do. Yeah. Yes.
Initially, the criteria for testing included traveling to certain areas, but as it's becoming more widespread, can you just speak to how that criteria has changed since we are seeing cases pop up?
When you go to the CDC website, and I did that this morning to try to anticipate this question, the list, the checklist is getting longer and longer instead of shorter. And I think eventually they will have to abandon the geographic restrictions because we're now seeing spread in the community without a history of travel outside the continental U.S. So yeah, those are criteria that are just changing. We're keeping up with it. If there's a patient that needs to be tested, whoever is seeing that patient here will access those criteria promptly and always have access to the most recent guidelines. Is that a good enough answer? Okay. Yes?
Do we need to get those N95 masks for those?
Who is we? Who do?
I mean, just, I don't know.
The question is about N95 masks. I don't have one. I don't know that I could fit one on the hair on my face. I plan to, or when I went to see the patient that was admitted through the emergency department, I put on the surgical mask with the face shield, gown and gloves, and spent a few minutes in the room. I mean, I examined the patient and talked to her for a little bit, but I didn't stay in there half an hour. I think the N95 product has probably been a little bit exaggerated. How's that for a statement?
Thank you.
Yes.
I have a question about the basic reproductive number.
Yes.
It says that spread infection is approximately 2.2 other people. How does that compare to other infectious diseases like common flu and stuff?
They're estimating that basic reproductive number, which is an epidemiologic tool, and currently they're arguing about it. So I don't know that comparing it yet to influenza, the common cold, etc., is something that can be reliably done at this point. If you go to the IDSA website, and I think all of the coronavirus information is available to non-members, but if you go to the IDSA website, there is a section of that, and someone posted a comment about that within the past 3 or 4 days that I was looking at this morning, and they think it's probably going to end up being as transmissible as the common cold and pretty readily spread from people that are excreting the virus to susceptible individuals. So I think that number is probably going to end up being higher than 2 or 3. But basically, time will tell. Maybe in 6 months, I'll come and give another update on what happened, and maybe it'll be over by then. Yes?
Does the flu vaccine have any effect on it?
No. The flu vaccine has no effect. Other questions? You let me off easy. Thank you very much.